Teresa and Susan, for this kind introduction. Good afternoon, everyone. As you may know, I will be co-moderating this session with Dr. Asteggiano today. Before I start, I would like to thank the organization for choosing us as chairs. My name is Isabel Rodríguez. I'm a radiation oncologist. I currently work at La Paz Hospital in Madrid, where I coordinate the brachytherapy unit and collaborate actively with the Cardio-Oncology unit. Dr. Asteggiano will now briefly introduce himself before we start. Please, Riccardo, you can start.
Thank you, Isabel. Thank you, Teresa, for involving us in this exciting activity of this Congress of Cardio-Oncology that probably will be the most important Congress about this issue in this strange 2020. I am the past chair of the Cardio-Oncology Council of the ESC, and I am a professor at the University of Insubria near Varese, Milan, School of Medicine. Please, Isabel. Thank you.
Okay, thank you, Riccardo. Okay, a little bit presentation. The objective of this session, as Teresa said, is to address from a practical point of view the current of understanding a cardio-oncology unit. Our invited speakers will focus on three key aspects: the essential, the opportune, and the optional features of a cardio-oncology practice. After the speakers complete their presentations, we will open a round of questions. If you want to pose any question, please do it through the available form, a chat. Please be concise and indicate who you are addressing the question to. Now it's time to start. Our first speaker is Susan Dent. She is a medical oncologist, associate director of the Breast Cancer Clinical Research and co-director of the Duke Cardio-Oncology Program at Duke University in Durham, USA. Her areas of interest include breast cancer, treatment toxicities, and cardiotoxicity. She is the founder and past president of the Canadian Cardiac Oncology Network and vice president of the International Cardio-Oncology Society. Please, Susan, you have now the microphone.
Thank you. Thank you to the organizers for giving me this opportunity to open this session focusing on cardio-oncology care in 2020. And over this session, you'll hear from three different experts in the field that will discuss about, give you an overview of where they think cardio-oncology care should be in 2020. So these are our disclosures, as you see here. So what does a cardio-oncology program look like, and what are the components of a program? I think that for those of you joining this conference today, some of you may have already started a program. Some of you may be thinking about starting a cardio-oncology program. And there are those who may have had one that's been going for a number of years. But I think what we hope to do in this session is really to sit back and reflect that no matter where you are and where, in terms of a program, what are some of the components that are essential to that program? What are the opportunities that your program can give you? And what does the optimal program look like in 2020? So from my standpoint, what are some of the essential elements of a cardio-oncology clinic and program? It may seem quite intuitive, but a multidisciplinary team, I think, is key when developing a program. And we often talk about oncologists and cardiologists, but not only do you need to have these people working together, you really do have to have engagement of both of those subspecialties. But it's not just about cardiology and oncology. It really is a team that should be including people such as pharmacists, nursing, exercise physiologists, family physicians and primary care providers, as well as a number of allied healthcare providers. So we can't just focus on those two subspecialties. We want to sort of open that envelope because remember, this is a population that we're going to be looking at from the time they're diagnosed all the way through to survivorship. A program needs adequate resources, and those resources can be in the form of staff, financial resources, as well as space to conduct your cardio-oncology clinic and your program. And then importantly, you need support of administration. You need senior administration to really step in and support what you're trying to do. And that also means providing you with some financial support for the resources that are needed. So those, and of course, sort of over top all of this, what you really need is you need a champion. Unless you have a champion in your clinic and in your program, it's really going to be hard to move this forward. So it's not just enough to be engaged, but you do need a champion. So when you look at developing a clinic or a program, what are some of the opportunities? Well, first and foremost, in the center of this diagram is the clinic. Our goal is to provide optimal care for our cancer patients. And ideally, that would be in the form of having a multidisciplinary clinic with all of those individuals I mentioned earlier to provide multidisciplinary care, both for those individuals who develop cardiovascular toxicities and issues, as well as moving forward to preventative approaches for those at risk. But there are other opportunities. Clearly, having a program gives you the opportunity to provide education for patients, for other healthcare providers, for the public, as well as to consider fellowship programs. And we've seen this growing across North America and globally over the last few years, where now we're moving towards training future cardio-oncologists. Also, there's the opportunity for research, and you'll be hearing a bit more about this from my colleagues. That research can stem all the way from translational research, where we need to look at understanding the mechanisms of cardiovascular toxicity, particularly of the newer targeted therapies, through to looking at what are the optimal imaging strategies and how do we diagnose cardiovascular toxicity earlier? What are the biomarkers that we might be able to use? And also outcomes. What happens to these people? For those people who develop cardiovascular toxicity who were not seen by us, and those who were treated, and can we actually prove that we're actually doing a service to these patients, that we're improving their clinical outcomes? And then finally, the last thing is survivorship. These patients will complete their course of cancer therapy, and then they will go back to their primary care providers or family physicians. What happens after that? And there is a whole session dedicated in this meeting to talking about survivorship. And optimally, at a very high level, this is what I think a cardio-oncology program should look like. You need support and engagement from all levels, including your university, your hospital administration, senior management, and the department that you are in, whether it be medicine or another department. You need a solid clinic that is multidisciplinary in its approach. Ideally, you need a cardio-oncology training program and support from a postgraduate training office. And then around that, you need to consider your educational opportunities, research that is supported, clinical training as we move towards the future, and ensuring that we have cardio-oncologists to take care of these patients in the future. So with that, I will hand it over to my next colleague to give their comments on what they think is the essential, the opportune, and the optimal.
Okay, thank you. Thank you very much, Susan. Very interesting. The next speaker is Susie Stanway, who is a consultant in medical oncology at the Royal Mater Hospital in London, UK. She treats breast cancer and has a research and education interest in cancer survivorship, particularly cardio-oncology and in cancer control in low and middle income countries. So please, Susan, go ahead.
Thank you very much for that introduction and for inviting me to give my thoughts today. So I think for the essential components, I've divided these into clinical and diagnostics. I think from a clinical perspective, it's an imperative that we not only have adequately trained oncology healthcare professionals who are seeing cancer patients in clinic and who have a firm and full understanding of how to pick up potential cardiotoxicity from the treatments we use, but also that cardiologists who these patients are referred to also understand the oncological implications of why we're treating these patients and what we're trying to achieve, so that they can work together to help us keep patients on treatment where appropriate and support them from a cardiological perspective. I also think that it's important that we don't just see patients for standard surveillance and in the reactive setting who develop toxicity, but also that we see patients proactively. And we'll come on to that in the next slide in a minute. From a diagnostic perspective, I think it's really important that we have access, that everybody has access, given the potentially cardiotoxic drugs, to a cardio-oncology MDT, as Dr. Dent has just described, and also that there are clear referral criteria, so that we know who we should be referring, and that this is totally clear. I think it's essential that there is access to timely ECG and resting echocardiography, the latter of which doesn't involve any radiation, unlike Mugger scans, and also that we have access to serum biomarker measurements. And there was a great position statement from the ESC published, I know, led by Dr. Lyon, which gives much more information on this. From an opportune perspective, I've put up this picture from another paper that Dr. Lyon and collaborators have recently published. So I think that the baseline before we start treatment is a fantastic opportunity for us to try and improve cardiovascular morbidity, but also to try and keep our patients on drugs for the optimal time and in the metastatic setting for as long as they need. And so they have developed some proformas, which I know Dr. Lyon is going to talk about a little bit more, which factor in medical cardiovascular risk factors, lifestyle cardiovascular risk factors, cardiac biomarkers, previous cardiotoxic cancer treatment, and previous cardiovascular disease. And this is becoming more and more important as people are living longer. Many of the novel drugs coming out have got potential cardiovascular toxicity readouts. And so this is becoming really, really important, and potentially risk stratifying patients at baseline and then referring where appropriate in a proactive way is really going to be the way forward. And what's the optimal? So I put in the top part of my slide, going above and beyond. So I think prehabilitation is going to be incredibly important. And this is all about promoting good health and giving our patients tools to empower them to develop resilience to stay on treatment. And there are many risk factors that are common to cardiovascular disease and cancer. And so this is really a win-win situation. I think providing patients, where possible, to access to health and wellbeing events, certainly in the institution where I work, this is part of the recovery package. And these are events where patients are educated and can be empowered to improve their own cardiovascular health. From a diagnostic perspective, I think that we should all have, if possible, in the future, rapid access to ambulatory monitoring, including Holter ECG and 24-hour blood pressure, and access to advanced imaging techniques such as stress echocardiography, CT coronary angiography, cardiac MRI, and cardiac FDG PET. And again, there's relatively recently been a great position statement published in collaboration with ICOS and the ESC by Dr. Lyon. And from a research and audit perspective, I think it's really important that we all have well-maintained, audited databases so that we can reflect on our own unit experience. And that we are research active, as Dr. Dent has already alluded to, and participate in active oncology collaborations. Thank you very much.
Okay. Thank you, Susie, for your excellent analysis. Okay, the last speaker is Alexander Lyon. He is a senior lecturer in cardiology and, sorry. Sorry, the last speaker is Alexander Lyon. He is a senior lecturer in cardiology at Imperial College London and a consultant cardiologist at the Royal Brompton Hospital in London, UK. He is the clinical lead of the Cardio-Oncology Service at the Royal Brompton Hospital since 2011. He's the current president of the British Cardio-Oncology Society and the chairperson-elect of the European Society of Cardiology Council of Cardio-Oncology. So, Alexander, you can start now.
Thank you, Isabel and Rick, and thank you to the organisers, Teresa, Jose, Dan and Susan, for putting together this meeting, because of course we'd all love to be together in Toronto, but this has not been possible, and to now have a virtual Cardio-Oncology Summit is a real advance and a first as far as I'm aware in the world. So thank you to the organisers. And you've heard a lot already from Susan and Susie about the key ingredients to an effective cardio-oncology service and program. So I'm going to now hopefully build upon that with some further thoughts. So communication is key. We've heard about the people who need to be in the team, and it's about how you then communicate. For cardiologists, we need to learn the language of oncology, and very importantly, the efficacy of the drugs and the magnitude of benefit. And for the oncologists, they need to understand the language of modern cardiology and what we can contribute. And so we can then have the discussions in an informed way about the risks and benefits of proceeding with particular oncology therapies versus choosing alternatives. Speed is essence, because often cancer treatment is being delayed or interrupted pending the decision from the Cardio-Oncology Service. And therefore, it's really important to have rapid communication pathways from the oncology team to the cardio-oncology team and backwards with the results and the decisions. So this is about working together as a team, whether it's within your cardio-oncology service or from that to other services in your region where you live and work, and also to the other oncologists or cardiologists in your hospital. And we've heard a lot about education. I think our patients need to understand these decisions so they can also make informed decisions with appropriate consent. And all the team members that Susan mentioned that are key to delivering an effective service, in addition to the medical professionals. But if you had to take one take-home message, it's that we should not be stopping effective cancer treatments unless it really is a cardiac emergency and there's very serious heart issues. So we've got to be having our mission to support the best oncology care rather than trying to stop it or obstruct. On to the opportunities. So earlier this year in May, there was a publication from the Heart Failure Association Cardio-Oncology Study Group in collaboration with the International Cardio-Oncology Society, where we put forward this concept of how baseline risk stratification can be performed. This is to be delivered in the oncology and hematology clinics and wards in order to risk stratify a patient from a cardiovascular perspective before they start their treatment. And we picked several categories of treatments, including anthracycline chemotherapy, HER2-targeted therapies such as trastuzumab, proteasome inhibitors and multiple myeloma therapies, and so forth. Drugs and treatments which we know can cause cardiovascular problems. And for each one, we've created a single one-page pro forma, and these are able to be printed out or downloaded from the article, so you can have these in your clinic and use them in the patient's medical record. And essentially, you have a series of factors where you can identify, are they present in a binary yes, no phenomenon? And then with this, you can give a score, a risk category score to the patient. If they have no risk factors or only 1 point, they're low risk. Once they accumulate points in the range of 2 to 4, they're medium risk. And then from 5 and above, they become high risk. And of course, there are some very high risk factors. And my opinion is if you have a patient who's has this risk calculation and they're high or very high, then they should ideally see a cardio-oncology service for a review to personalize their monitoring and potentially think about primary prevention therapies up front and optimizing any pre-existing risk factors or cardiovascular disease. And in a second paper, with the first authors, Yelena Shuluchkina from Lithuania, the HFA Cardio-Oncology Study Group in collaboration with the EACVI imaging experts from the ESC, put together a concept that you can take this personalized risk stratification and then with the next step, define the monitoring. So for low-risk patients who are receiving, in this example, 6 cycles of chemotherapy containing an anthracycline, maybe this is R-CHOP chemotherapy for lymphoma, for low-risk individuals, as well as the baseline assessment, they'll need a follow-up assessment. But you can see that as the risk rate rises, closer monitoring is required, so we tailor this to the patient. Finally, thinking about what is optimal. So currently in 2020, as you've heard, we need access to advanced imaging, and more we're using cardiac MRI and cardiac PET-CT to assess for inflammation, myocarditis in patients' hearts, as well as other forms of imaging. We're now considering using genetic testing for cardiomyopathy-causing genes in certain individuals, particularly patients who develop heart failure or significant left ventricular dysfunction in the absence of conventional risk factors. It's really important to collect your outcomes, and we'll no doubt discuss how do you win the hearts and minds of your hospital administrators and your managers. And I think proving what impact your service has, and particularly that it's cost effective, is critical. And then the delivery of current trials so that we can guide the future's best practice. Thinking to the future, I think we're all working now in a digital world, as these conferences show. And I think collecting data digitally is going to be one key element of this. And I can see how we can create softwares to help with that risk stratification and the protocols for surveillance. Also then collecting data across all our centers globally so that we can gather registry data and then be able to understand what happens when thousands of patients are given a particular drug.
Alex,
more and more our patients are wearing wearables, and we need to consider that data, and then how we analyze the data, which is with AI as one concept. And finally, we live in a world really disrupted by COVID. And I just want to highlight this article, which hopefully you've read, and if not, you can have access to, published by the International Cardio-Oncology Society, to show how we can adapt our services in the COVID era. If you look at this key central figure, what you'll see is that as well as what we're used to doing, which is stratifying by cardiovascular risk in the left middle panel, and by oncology or cancer risk in the middle panel, we can now integrate COVID risk depending on whether COVID is prevalent in your community at the time you're delivering care. So there's a lot more information in the article, and I hope that's helpful to how we deliver our care now, as well as looking to the future. So thank you again, and I hand back to Isabel and Rick.
Okay, thank you, Alexander, for this complete presentation. Now it's time for questions. We have 15 minutes for that. Please, Riccardo, there is some questions from the...
Yeah, there are 2 questions from the audience.
Go ahead.
Thank you to all the speakers about their presentations. The first one is coming from Lyon, that is asking to Susan Dent, how do you get your administration at your hospital being engaged in cardio-oncology services? And this, I think, is a common problem for all of us. How may we go to our administration and ask, I want to open how to present things to our administrations?
think that's a very good question, and I think it's a question that many of us struggle with. While we, in our own minds, feel that opening up these clinics will provide a valuable service for patients, administration looks at dollar signs in the end, and they will wonder, well, how much is this going to cost for me to run a program, and what are the outcomes that will prove that this is effective? So having moved recently to a new center, I also was faced with the challenge of trying to convince administration that this would be a worthwhile endeavor. And I think beyond telling administration about the importance, you really do have to come with some data. So what you do have to do is you have to go into your experience at your center and show, and for instance, what we've done here at Duke is this is the number of patients that we have treated in our oncology centers, both in the infusion center and with these oral therapies. And these are the problems that we've encountered. So we've actually looked at 3 years of data here at Duke to show all the encounters with cardiology from our oncology patients and what's happened to these patients and hospitalizations associated with those issues that came from the cancer therapies. So going to your administration with data, if at all possible, to show that, first of all, cancer patients are being seen by cardiologists, but perhaps not in the most effective and efficient manner. And then two, as you're setting up your clinic and your program, what kind of outcomes are you willing to look at? So are you going to look at, for instance, decrease in visits to the emergency department? Are you going to look at decrease in hospital admissions? These are the things that hospital administrators like to hear about, because to them, these are things that cost money. So it really speaks to, when you're setting up a program, it's not just good enough to set up a program. You have to justify it by looking at your data and showing that these people need to be seen. And two, is sort of backing what Susie said earlier, you have to measure your outcomes. You have to collect the data from your clinic, and you have to show administration, look at this is what happened before, and now since we started this clinic, we have people that are finishing their cancer treatments, they're not going to emerge, we're treating them proactively. And I would say an appeal to all of those out there who are starting programs or have programs, this is really important to do. And if you look in the literature right now, we do not see a lot of outcome research in terms of what's happened with our clinics. So Dan, I know that's, I hope that answers some of your question, but I think we have to go to our administration with data. They understand data, and we have to show them that this is a reasonable thing to do.
Thank you, Susan. A question for Alex. Always standing on how to convince people, how to convince skeptical oncologists of the value of cardio-oncology services. And I may also have how to convince skeptical cardiologists about the need to know something about cardio-oncology.
Okay, thank you, Rick. Two challenging questions. And I'm going to approach the first part, how do you deal with skeptical oncologists, partly by thinking of Susan's answer as well. So it's about showing that you can improve outcomes. And all oncologists are most interested in the outcomes of their patients, cancer-free, so they're cured or living with prolonged longevity if the cancer is controlled. And through cardio-oncology, by risk stratification and closer monitoring of high-risk patients, we keep people on treatment for longer. We prevent interruptions. And whichever the malignancy is, if you have an evidence-based treatment that improves outcomes, you've got to be on it to get the benefit. And therefore, if you, in collecting your data, can start to show the impact of your service on improving adherence to evidence-based oncology therapies, that then leads to improved outcomes, which we're starting to see if you now put in 5-year or 10-year follow-up. And from that, that's dynamite. And if you can win the hearts and minds of the head of your oncology and hematology departments, they can then filter down the strategy to their colleagues, including the skeptical colleagues. and also to administrations so that oncology and hematology departments contribute to the funding of the cardio-oncology service. To cardiology skeptics, I think just look at what you're seeing in your services. I speak to many colleagues who tell me across Europe and the world that now between 10 and 15% of all echocardiography done in cardiology services is on cancer patients. That's an enormous amount. So we've got to think about how we deliver it efficiently, effectively, and who's paying for it. Should cardiology pay for all this scanning in oncology patients, or should there be a collaboration? So to the skeptical cardiologist, nothing like a bit of extra funding coming from our oncology neighbours to help catalyse this. So, and then it's collecting the information, proving better outcome, and finally the patient voice. Collect feedback from the patients, and I can guarantee you they love having the care and attention to their cardiac health as well as their cancer health, particularly if it keeps them on their cancer treatments, because they're very frightened when they're stopped or interrupted or delayed. And then that feedback is also really important to go to the skeptics. Thank you.
Well, we have other questions about the education. What we recommend to and how may we recommend education for physicians that are interested in cardio-oncology? This is for all the panel.
Maybe I can start and then I'll hand over to my oncology colleagues. So from a cardio-oncology service perspective, now many services across the world are running fellowship programs, and we've been having fellows from all over the world to come to the Royal Brompton Hospital to learn and see how we approach the different challenging clinical questions that get posed to us, but also how you implement, you set up the service, the governance of the service to ensure it's safe and effective, and then the discussions on funding and expansion. So now there are more and more fellowship programs which are available. I know that ICOS and the ACC have collected a list, so those websites have information, and that previously there's been a curricula about 4 years ago published, but a new one is in preparation with Dan Lenihan leading it from the ICOS server team. So watch this space for really the granularity of what training is required to be accepted. Now, I think you can enter this from cardiology or from hematology and oncology. So we welcome trainees from both fields to come to cardio-oncology services and learn how we deliver the effective care. I'll now maybe hand over to Susie next, and then on to Susan.
Yes,
I'm sorry, Riccardo. We don't have time for more questions. So it's very interesting, but the time is the time. So after this round of questions, Dr. Asteggiano will now conclude with some final remarks. Okay, Riccardo?
Yeah. So sorry for that, but we need a couple of hours to debate all the questions we received, and all the questions are very interesting and are going in deep in all your presentations. Well, for summarizing this very exciting session, the essential, and what may be important for cardio-oncology today, I think that we have to think to what are the goals of cardio-oncology today, and essentially they are the prevention, the early diagnosis and treatment of cancer therapy-related cardiovascular complications. This is for the optimization of long-term acute cardiovascular and acute cardiovascular health of our patients, and also to allow the reduction of interruption of anti-cancer drugs, as Alex said. And this is based on effective communication and coordination of the cardio-oncology services and centers. This means that we need to increase our organization, first of all. This is essential. We need to increase our education for all people involved in the field, beginning from the patients and to the physicians involved, to the general practitioners, to the nurses, but also to the community, and also to the administrator and to the politicians to reach the adequate resources to sustain our services. And this is, for the future, one of the most important issues for cardio-oncology, to go a step forward and show the necessity to improve the cardio-oncology services and the cardio-oncology centers. The future also will be probably a digital future. And we will see in next year what will be about this. I would like another time to thanks all organizers or the organizers of this session. Teresa will spend a lot of time for involving us in this. All the speakers that did a very good job in managing this very complex issue in 15 minutes altogether. So it is a very huge race. And I think that we will need to have more of this kind of meetings for the future. Thank you to all.
Okay. Thank you very much, Riccardo, for your words are very complete. So now we will end this session. Thank you very much, Susan, Susie, and Alexander, for your meaningful contribution to this session. We will also like to thank all the people who is following this virtual summit through the web, and also the scientific societies and the sponsors of this meeting for their great support. Finally, I would like to say that we have to keep in mind everything you said. One more thing, don't miss the next live session started in 5 minutes, entitled Year in Review, the Evolving Field of Cardio-Oncology. So that's all. Goodbye, everyone.
Goodbye.